Every year, almost 60,000 infants are hospitalized with RSV. More than 130,000 present to the emergency department for acute evaluation. RSV is the #1 cause of respiratory failure in infants less than 1 year old, and almost 100% of kids are going to get RSV by the age of 2. But in my experience, a lot of parents know very little about it. My name is Brandon Hunter. I'm a board-certified pediatrician and pediatric ICU doctor at Texas Children's Hospital. I did my general pediatrics training in Boston Children's and a pediatric critical care fellowship at Children's Hospital of Philadelphia. I've taken care of hundreds of kids with RSV in different settings, in the clinic, in the ER, and now primarily in the intensive care unit. And parents often ask me for a list of symptoms or warning signs to look out for when their child has bronchiolitis, and questions about what's going to happen when they get it. And those are super important topics. But I will say, if you really want to understand it, I think you have to get the basic science, the anatomy and physiology of what's happening when your child gets infected with RSV. And so that's the point of the video today. We're going to talk about 3 things. What is RSV and how does it spread? What happens to the body during an infection, and then which babies are at highest risk, and how might that impact how we think about the disease? So we'll jump right into it. RSV stands for Respiratory Syncytial Virus. As the name implies, it's a virus that tends to infect the respiratory tract. So just remember that viruses in general have what's called tropism, or there are certain types of infections they tend to cause. So hepatitis viruses tend to infect the liver, norovirus tends to infect the GI tract, and here RSV tends to infect the respiratory tract. I think of it pretty similar to these other viruses: parainfluenza, rhinovirus, adenovirus, enterovirus, human metapneumo. The list goes on. But they're all similar in that they all infect the respiratory tract, and we don't really have medicines that we use to treat them directly. Usually, we just support the infant or the child until their body can fight off the viral infection. It's just a common rule. Certain viruses tend to cause certain diseases within the respiratory tract. So RSV is commonly associated with bronchiolitis, causes 50 to 80% of the cases. Parainfluenza commonly causes this kind of throat infection called croup. And then rhinovirus is most commonly associated with the common cold. But any of them could cause these different infections depending on which structures or which parts of the respiratory tract they infect. And then I'll make one more point. I put COVID and influenza on this list, but I left them unbolded. So they also infect the respiratory tract and can cause different illnesses there. But they're a little different to me only because we have antivirus medicines or antiviral medicines that we can use to treat severe, moderate, or severe disease. So they're a little bit different to me. How does it spread? Well, direct inoculation is the most common. So if a child sneezes or coughs and some of that saliva or mucus that's infected with RSV gets into someone else's mucous membrane, so in their eyes, in their nose, in their mouth, then that can just cause a direct infection right off the bat. But a second critical way that it spreads is through contact. So there's a term called fomites, and it basically just means like hard surfaces. So a computer mouse or a mug or a phone, if somebody touches those things with virus or viral particles on their hands, the virus can live there for 3 to 30 hours. So if you pick it up and then end up touching your eyes, nose, or mouth, you can actually get it through a contact spread. And so that's why during RSV season, washing your hands is just really, really important. And so on that note, what is RSV season? Well, every year in the intensive care unit and in pediatrics in general, we know about viral season or RSV season. And this is where hospitalizations and infections related to the virus tend to spike. And so this is a great graph. It's from the CDC. They have something called RSV Net, where they track the hospitalization rate over time based on the month during the year. And this is the graph for 2023 into 2024. And you can see that the peak RSV season was right here in December going into January. And this is the most common time that it tends to peak. We had a little bit of a change with COVID and isolation, but it seems like we're starting to get back onto that same pattern as before. I will say at my hospital, I'm recording this in early November, and we've started to see an uptick in the number of children hospitalized with RSV. So I think we're on a similar pattern compared to last year, but we don't really know until we see. All right, so that's what it is. That's how it's spread. Now, where does it infect? So you don't have to be super in-depth about the anatomy here, but we should understand a little bit about the respiratory tract to know what happens when it infects certain tissues. So we'll just trace air from the outside environment down into the lungs and how it gets into the body. So this is called the conducting zone. All the structures here are essentially just trying to get air from outside to the lungs to do gas exchange with the body. So it starts at the nose or the mouth and then moves to the back towards the throat, And in this case, we use the word pharynx. So up here, we might say nasopharynx, and down here, oropharynx, but essentially just the back of the throat. From there, it goes to the larynx. We often call that the voice box. This is where the vocal cords are and where you get sound generation. The middle of those vocal cords, we sometimes use the word glottis, but the critical part about this structure is, to me, it's really the entrance into the lower respiratory tract where the lungs are. So from there, it goes down the trachea, which goes from your neck down into your chest, and probably about at the nipple line, maybe a little bit different in infants. It'll break off into two structures, which are called main stem bronchi. Each bronchus, which is going to a different lung, branches again into segmental bronchi. They keep branching, and eventually you get these really small tubes that we call bronchioles, but you're still just transmitting air to those final lung units. What are those final lung units? Well, they're pictured here. It's called the alveolus, or plural is alveoli. And they're basically just these air sacs that have a really thin membrane and are associated with blood vessels. So this is where gas exchange happens. It's really where the lungs do their job. And I'll say, I'm an intensivist, and so for me, I have very kind of simple thinking about the lungs. Two jobs. First job, get oxygen in, and second job, get carbon dioxide out. And so that's really how air flows in. Let's take a look at a graphic of it. So in this video, don't worry about the stuff on the left, these pressure time loops or the ventilator, but you can imagine that air, which is full of oxygen, comes in, and here is green, goes down the trachea, bronchus, bronchi, bronchioles, and eventually gets to the alveolus. And so you can see oxygen comes in here and then gets picked up by the blood vessels and gets taken to the rest of the body to help the body essentially stay alive, but do the work of cellular respiration and keep the vital processes going to maintain life. It then comes back to the heart and then to the lungs eventually with a bunch of waste. And the waste product specifically is carbon dioxide. And so you can see that in red here, it gets dropped off into the alveolus and breathed out through the bronchiole, the bronchi, and then the trachea. And so that's kind of how air comes in, how gas exchange happens, and then it goes out. But let's learn a little bit more about the mechanism of breathing. So when you inhale air, what's happening? So we've got the lungs in the chest, we have what's called the chest wall, and then the diaphragm. I'm going to pause here for just a second because the diaphragm is such a critical muscle. So at rest, there's a dome-shaped muscle sitting just below your lungs, on top of your liver on the right and the spleen on the left. And when it contracts, it essentially opens up the chest cavity and pushes your abdominal contents down to make space for air to come in. At the same time, there's muscles in your chest that open up the ribs, and all this is doing is essentially opening space where air can flow in passively. And so we'll see this during the process of inhalation, talk about the diaphragm and the ribs, and essentially we have an increase in volume of the chest. What that does is it reduces the pressure in the chest, and so air just kind of passively flows into the lungs, down the bronchi, bronchioles, and gets to the alveoli that you can see there. When you breathe out, the opposite happens. So the diaphragm relaxes, the chest muscles relax, and the volume goes down. So there's more pressure in the chest and air flows out. And that's about it. All right, so now we understand the anatomy and the physiology of how the lungs work. Let's talk about what happens when there's an infection. So this is called the pathophysiology, but what happens when there's infection of different structures along the way? So we can start off, and you remember I said that the voice box to me, or the larynx, was a critical separator between the lower respiratory tract and the upper respiratory tract. So if you have an infection above the larynx, it's often called a URI, or an upper respiratory infection. This can take different forms. So the common cold is rhinosinusitis or itis. Whenever you see that, it just means inflammation. And then rhino usually refers to the nose. Sinus, of course, refers to the sinuses. And so if you have inflammation of the nose and the sinuses, kind of common cold. You can have otitis media, and the OT kind of stands for the ears. So if you have inflammation of the middle ear media, or an ear infection, then you would also say that's another type of URI. You can have croup, and in this case, it's an infection right around the larynx or right around the voice box. You often hear that like high-pitched breathing with infants where there's a bunch of inflammation and swelling, and so it's hard for air to pass around it. This is also, the technical term is laryngotracheitis. And once again, you see that itis, or inflammation of the larynx, inflammation of the trachea and tissues around it, and that's kind of where the name comes from. But these are all upper respiratory infections that could be caused by RSV. Below that, you have lower respiratory tract infections. And in this case, bronchitis is the first big structure along the way that can get infected. And so if I got RSV in my lungs, or an older person did, bronchitis is the most common thing you're going to see. If an infant gets RSV into the lungs, the most common result is bronchiolitis. So it gets to the distal tubes, or the tubes that are further down towards the alveolus, and they get inflamed. And then if it actually gets into the alveolus itself, those air sacs, then you would call it a viral pneumonia. But bronchiolitis is really the diagnosis to focus on, and this is the cause of all that kind of staggering admissions and ER visits during the winter for children. So what's happening? Well, this is just a close-up of those terminal bronchioles that are taking air to the alveoli. And all the issues really come from the fact that these bronchioles are inflamed and kind of collapse down. So for some of the lung units, the alveolus wants to get air in, but it can't inflate. So this is actually called atelectasis, or there's lung collapse. But interestingly, some other lung units have the opposite problems. They're actually able to get air in, but now they're not able to get air out. So you have air trapping. In both cases, it's not good, because if you have trapped air, you're not going to get fresh new oxygen with each breath. It's just kind of sitting there, and the oxygen will get used up pretty quickly, and then the air there is doing no good. And then similarly here, if you can't get oxygen in, you can imagine that's not good for the body in general. So the issue all comes from these little tubes or little conducting airways being occluded. So you can imagine, it's really like a bunch of little straws, right? If you're sucking through a straw, and the straw is big, and you're just sucking air in, or Diet Coke, then it's usually pretty easy. But in this case, if there's occlusion or something really thick in there, then getting things through it is much harder. And so this is a kind of corny picture, but you can see this person, to try to get that milkshake moving through this small straw, they have to use a lot of effort. So that's what's kind of happening with bronchiolitis. So let's look at how the body responds when you have these, like a bunch of tiny obstructed straws, and you're trying to get air in. Well, remember, this is how we normally breathe. The diaphragm's doing most of the work. Everything's good. The lungs expand. The diaphragm contracts. And there's all these other muscles around, the rib cage, and they help to bring the chest open. But they're all firing just kind of nicely. Like, nothing's really flexing too hard. Air is flowing in and out nice and easy. Now we have other muscles around, the sternocleidomastoid, the scalene muscles, and these usually don't have to engage too much to really get air moving. But when we're in distress, or when we're having trouble getting air to the alveolus, they certainly can. And so you'll see them start to fire to really pull air in. And remember, at the end of the day, all this effort is just trying to get oxygen in and carbon dioxide out. You're just trying to get air to the alveolus to let it do gas exchange. Okay, let's close things out. What are the risk factors for severe disease? Well, basically, if you are small, young, or have chronic medical issues, then you're at higher risk of having a more severe presentation with bronchiolitis or requiring hospitalization. So small and young, less than 6-month-olds, premature infants, and then if you have chronic lung disease or reactive airway disease is a common diagnosis for infants, get exposed to secondhand smoke, or you have immunodeficiency or chronic medical illness, all these things make you a little bit more nervous that a child might have a severe presentation. All right, so for everyone who was able to stick it out through all that, good job. I really think this information is critical to understand the meat of what most parents care about. You know, what do I look out for, and when should I be worried when my kid is sick? How do we diagnose this thing, and then how do we treat it? That's gonna happen in the next video, but if you get this as a fundamental understanding, I think you're gonna be in great shape to understand all that. So thank you so much for your time and attention, and I hope you enjoy the next video as well.